If there's one topic in clinical pharmacology that really feels like, well, running a strategic marathon, it has to be tuberculosis. Welcome to the deep dive. Today, we are diving into Chapter 46 of Lilley's Pharmacology for Canadian Healthcare Practice. We're going to map out the very specific, kind of complex world of anti-tubercular drugs.
That's right. And our goal today really is to take this challenging material and boil it down into something clear, an action plan almost. We'll look at the disease itself, the clinical puzzle it presents, why the treatment is structured the way it is, using multiple drugs for months, sometimes longer, and crucially, the specific toxicities and those essential nursing checks needed to keep patients safe throughout that very long journey.
Okay, let's start with the main player here. Tuberculosis TB, caused by the bacterium Mycobacterium tuberculosis, or MTB. The nature of this particular bug really dictates the whole treatment strategy, doesn't it? MTB is an aerobic bacillus, basically, a rod-shaped organism that absolutely needs oxygen to thrive, which is why, it tends to set up shop in the lungs where there's plenty of oxygen.
But here's the key clinical point. It's a slow-growing organism, and that slow growth, that's the fundamental problem we face in treatment. Most standard antibiotics, they target cells that are actively dividing, metabolically busy. Because TB reproduces so slowly, many of these antitubercular drugs are just bacteriostatic, meaning they inhibit growth, they don't kill quickly, they aren't rapidly bactericidal.
So it's almost like we're fighting an enemy that likes to hibernate. That explains why you can't just blast it with a standard 7-day antibiotic course. The treatment has to be really persistent, right? Long enough to catch the bacteria whenever they actually decide to wake up and replicate.
Precisely, yeah. And because it's so tough to get rid of, the diagnosis has to be really rigorous. The source material lays out a pretty clear 3-step process. It starts with screening.
Okay, step 1. The screening test. So either the classic tuberculin skin test, the PPD, or the newer one, which seems often preferred now, the interferon gamma release assay, IGRA. Why are IGRAs becoming more standard, especially thinking about Canada?
Well, it really comes down to specificity. IGRAs are less likely to give you a false positive result, especially in people who've had the BCG vaccine against TB previously. They measure the immune response in a more targeted way. So that makes them a better screening tool when vaccination status might be a factor.
Got it. Okay, so if that initial screen comes back positive, then step 2 is getting a visual confirmation, a chest x-ray. And on that x-ray, we're looking for those classic signs where the body's tried to wall off the infection, those nodular clumps called granulomas.
Exactly. And then finally, if the x-ray looks suspicious, step 3 is the definitive diagnosis. That's a culture of sputum or maybe stomach secretions. Now, that culture takes time to grow, so a quick preliminary test is often done first, the acid-fast bacillus smear. It gives immediate info on whether the patient is actively shedding bacteria if they're infectious right now.
Right. And zooming out for just a sec, this isn't just an issue somewhere else. I mean, while Canada has a relatively low rate compared to globally, TB is a huge problem. It's second only to HIV in the number of deaths caused by a single infectious organism. That's staggering.
It is. And what makes it such a global threat now is this rising tide of drug resistance. We really need to differentiate the levels here. You have multidrug-resistant TB, MDR-TB.
Yeah.
That means resistance to the 2 main first-line drugs, Isoniazid, or INH, and Rifampin, RMP.
Okay, that's bad enough. But then there's the really scary one, extensively drug-resistant TB, XDR-TB. That means resistance not just to INH and rifampin, but also to a fluoroquinolone antibiotic and at least one of the 3 injectable second-line drugs.
Yeah, it's a serious situation. And this threat of resistance really underlines why prevention and, crucially, adherence to treatment are global public health issues. The source material is clear that susceptibility isn't random. We see higher rates of infection and resistance in certain groups, people with HIV, individuals experiencing homelessness or malnourishment, those on immunosuppressant drugs, residents in long-term care or correctional facilities. It's often that mix of poor health and inconsistent access to care that kind of fuels the resistance cycle.
That reality of XDR-TB really drives home why the treatment strategy has to be so aggressive from the start. So how is it actually structured to stop this slow-growing bug from developing resistance?
Well, it starts with the absolute necessity of combination therapy, always. To prevent resistant strains from emerging, sometimes called escape mutants, you must use at least 2 effective drugs at all times. The drugs are broadly classified into primary, or first line, and secondary, second line.
And even before you get the susceptibility results back, the standard approach hits the infection hard with a combination of the 4 main first-line drugs, right? And those 4 are really the core of our discussion today. Isoniazid, INH, Rifampin, RMP, pyrazinamide, PZA, and ethambutol, EMB.
Correct. The whole treatment process is typically broken into two phases, reflecting the sort of aggressiveness needed at different points. The first is the initial intensive phase. This usually lasts about 2 months, often using all four of those drugs, maybe 5 days a week. The goal here is rapid killing of the bulk of the bacteria and reducing infectiousness, which usually happens quite fast, often within just 2 weeks.
Okay, so knock them down hard initially. Then, once that's done, you shift into the second phase, the continuation phase. This sounds like the marathon part. It's variable in length, often 4 to 7 months, maybe longer, and typically uses fewer drugs, usually just two, like INH and RMP.
That's the typical approach, yes. And it's during this long continuation phase that adherence becomes such a major challenge. The chapter specifically calls out the need for directly observed treatment, DOT, especially if the drugs are given intermittently, like twice a week. This means a healthcare provider literally watches the patients swallow the pills. It sounds maybe paternalistic, but it's not about distrust. It's a critical clinical safeguard for patients who might be at high risk of not completing therapy, ensuring we actually cure the infection and prevent resistance.
Makes sense. Okay, let's really unpack these four essential first-line drugs now, one by one. Focus on their sometimes weird quirks and those are really critical adverse effects, starting with Isoniazid, INH, the cornerstone, really. It's bactericidal, works by messing up the bacterial cell wall synthesis.
Yeah, and what's really fascinating about INH is how your own genetics can affect how you handle it. It's metabolized in the liver through a process called acetylation, but some people genetically are slow acetylators.
Wait, kind of like how some people metabolize caffeine really slowly and others can have an espresso right before bed?
Exactly like that. If you're a slow acetylator, your body breaks down INH much more slowly. So the drug accumulates, builds up, and the risk of toxicity just skyrockets. The dose often needs to be adjusted, usually lowered, for these patients.
And that buildup leads to INH's most famous or infamous adverse effect. It causes a pyridoxine deficiency, that's vitamin B6, right? And without enough B6, the patient is at risk for peripheral neuropathy, that awful numbness, tingling, burning sensation, usually in the hands and feet.
Right. But the solution, thankfully, is remarkably simple for such a potentially severe issue. Usually about 25 milligrams of vitamin B6, pyridoxine, is given concurrently every day as a preventative measure. This is absolutely a non-negotiable part of nursing care for anyone on INH.
Okay, good to know. Moving on to Rifampin, RMP. This one's considered the powerhouse, the most potent drug, often allowing for shorter overall treatment times. It's broad-spectrum bactericidal, mainly works by inhibiting protein synthesis.
But RMP has that signature side effect you mentioned.
Yeah.
It's pretty much unavoidable. It causes this dramatic red, orange, brown discoloration of basically all bodily fluids. Urine, sweat, tears, sputum, everything. You absolutely have to warn patients about this, and specifically warn them that their tears can permanently stain soft contact lenses.
Right, so Rifampin turns you into a walking enzyme-inducing traffic cone, basically. But the color change, while alarming, isn't the main clinical danger, is it? It's a potent enzyme inducer in the liver. What does that mean practically? It massively speeds up the metabolism of other drugs.
Yes, and this is a critical drug interaction that can have really serious consequences. RMP makes many common medications less effective. Most notably, it renders hormonal contraceptives like the birth control pill ineffective. They just don't work well enough. So any patient capable of pregnancy who starts RMP must switch immediately to a reliable non-hormonal birth control method. Otherwise, there's a significant risk of unintended pregnancy. It's a huge counseling point.
Absolutely crucial. Okay, next up, ethambutol, EMB. This one is generally bacteriostatic, works by suppressing RNA and protein synthesis. Its main red flag seems to be related to the eyes.
That's right. It carries a severe risk of optic neuritis, inflammation of the optic nerve. This can lead to decreased vision, problems with color perception, even blindness in severe cases. And because accurately monitoring vision in very young children is extremely difficult, EMB is strictly contraindicated in kids younger than 13 years old.
Got it. Avoid in young kids due to the eye risk. Finally, pyrazinamide, PZA. Its mechanism is a bit murky, sometimes bacteriostatic, sometimes bactericidal, seems to inhibit lipid and nucleic acid synthesis.
Yeah, the exact mechanism isn't fully understood, but PZA adds another layer to that toxicity checklist we need to monitor. Like some others, it carries a risk of hepatotoxicity, liver damage, but it's also known to cause hyperuricemia, basically, high levels of uric acid in the blood. And for patients who are susceptible, this high uric acid can precipitate painful gout attacks.
Ouch. Okay. And before we shift fully into monitoring, we should just briefly mention those second-line injectable drugs like amikacin and streptomycin. These are powerful aminoglycosides, but they're reserved usually for resistant or complicated cases because of their own serious toxicities, right?
Exactly. They come with significant risks of ototoxicity, which means hearing loss or damage to hearing, and nephrotoxicity, which is kidney damage. So definitely not first choice unless absolutely necessary.
Okay, so we're asking patients to take this cocktail of drugs potentially affecting their liver, nerves, eyes, kidneys, hearing for months, maybe even years. This really highlights why the nursing process, the constant monitoring and education, becomes the absolute safety net for the whole therapy.
It really does. Before starting any of these drugs, the nurse needs a comprehensive baseline assessment. Think of it as the toxicity checklist. We have to know the starting point before we expose these organs to potential risks.
So which organs top that list for baseline checks?
Well, the big three are definitely liver, kidneys, and eyes. We absolutely need baseline liver function tests, bilirubin, liver enzymes like ALT, AST, and kidney function tests, BUN, creatinine, maybe creatinine clearance. But we also need a detailed neurological assessment, checking for any pre-existing neuropathy before starting INH.
And specifically for those high-risk drugs we just talked about, baseline hearing status, audiometry maybe, before starting aminoglycosides like streptomycin or amikacin, and baseline vision tests, acuity, color discrimination before starting ethambutol, plus that baseline uric acid level before PZA.
Precisely. You need all those baselines. Because the treatment, as we've hammered home, is long-term. Could be up to 24 months in some resistant cases. During the implementation phase, the single biggest piece of patient education is about strict adherence. It can't be stressed enough. Taking the drugs exactly as ordered at the same time every day for the entire prescribed duration. Any deviation, any non-adherence basically guarantees failure and promotes resistance.
And what about taking them? I remember reading absorption is often best on an empty stomach, but these drugs can be hard on the stomach, right?
They can be, yes. Significant GI upset is common. So while technically absorption might be slightly better without food for some, the source material notes they can and often should be taken with food. This helps minimize nausea and stomach irritation, which in turn actually helps improve adherence. If patients feel sick, they're less likely to take their meds.
Makes practical sense. And patients need to be hyper-aware of certain symptoms, right? Things they must report immediately.
Absolutely. They need to know the warning signs. Any signs of liver dysfunction, new onset fatigue, jaundice, yellowing skin or eyes, dark urine, loss of appetite, nausea, vomiting, report immediately. Any visual changes at all, blurred vision, decreased acuity, changes in color perception, especially with reds and greens for ethambutol, report immediately. Symptoms of peripheral neuropathy, that numbness, tingling, burning in hands or feet, report immediately. And critically, any new symptoms of gout, hot, painful, swollen joints, especially the big toe, which is classic for gout, triggered by PZA's hyperuricemia effect, report immediately.
That's a lot to watch for. So how do we know if the treatment is actually working? What's the goal we're evaluating for?
The ultimate goal, the therapeutic response we're looking for, is the complete resolution of the infection. And this is demonstrated by objective signs. A clear decrease in symptoms like cough, fever, night sweats. Positive signs like weight gain are also good indicators. But most definitively, we look for negative sputum culture results, meaning no bacteria are growing, and clear improvement on follow-up chest x-rays.
Okay, this has been a really dense but crucial overview, a massive synthesis of this chapter.
It really has. And I think the core takeaway for you, the listener, is this. Treating TB is truly a strategic marathon. It's defined by these very specific drug combinations. And just as important is the vigilant patient monitoring required to manage that predictable but potentially serious set of toxicities.
Let's just quickly nail down the three absolute clinical must-knows from this deep dive.
Yeah.
Number one, adherence. It is the absolute linchpin for cure and for preventing the nightmare scenario of MDR-TB and XDR-TB.
Number two, Isoniazid, INH. It requires concurrent supplementation with vitamin B6, pyridoxine, to prevent that potentially devastating peripheral neuropathy. Don't forget the B6.
And number three, Rifampin, RMP. It's that powerful enzyme inducer. It turns body fluids red-orange, yes, but critically, it will make hormonal contraceptives ineffective. That drug interaction demands mandatory counseling.
Definitely. And, this clinical complexity, it really connects back directly to the global fight against infectious disease. The single greatest threat to controlling TB worldwide is patient non-adherence. When people don't finish their treatment, that's what actively fuels the creation of resistant strains. It really highlights why the intensive patient education and that vigilant nursing monitoring we talked about, watching for side effects, ensuring follow-through, why these aren't just routine care tasks, they are truly global public health imperatives.
A powerful point to end on. We've given you the tools to understand this critical challenge. Now maybe go mull over the difference between a slow acetylator and a fast acetylator and why it matters so much here. Thank you for joining us for this deep dive.